It is my pleasure to be here today and share with you on this topic, which I have been doing for the last several years here at NDSC, and I just truly enjoy being able to share the information that I have so that families from all over are able to really understand the healthcare guidelines. One of the things that we know is that even physicians, pediatricians, family practitioners are just they have a harder time really kind of keeping track of all of these guidelines. It's a good 13, 14 pages long when you look at the guidelines. And so to know what kind of health issues to expect and what to watch for can be a challenge. And so it's good for families to really be aware of these things. So I don't make any extra money from anywhere, so I'm not going to sell you anything today. That's a good thing. And today we're going to talk about the healthcare guidelines. I'm going to talk to you about the guidelines recommendations, but also things that are not addressed in the guidelines that after doing this now for many years in my job, I can share with you some of my own personal opinions on some of the things that families ask me about frequently. We will be having Ask the Doctor sessions as well. We have two of those that we'll be doing this afternoon. Will be one focused on teenage and adult issues in Down syndrome, and then tomorrow morning at 8:30, same time, we'll be having one on pediatric issues. So we should have a few minutes after the session today for questions, but definitely if you have more, come on by the Ask the Doctor sessions. Those are a lot of fun as well. And then we're going to be talking about what a Down syndrome center does. If your area doesn't have one, your region maybe may not have one, what's the role? Why should you really work as parents towards trying to get your local hospital and health systems to have a Down syndrome center in your area as well? So healthcare guidelines really for people with Down syndrome is a relatively new thing. In the 1970s really is when people started to recognize that it's probably important to have some sort of guidelines in place for people with Down syndrome. And they had a lot of expert kind of opinions at that time, but no data, no information that really was there that was evidence-based. And then in the 1990s, what's called the Down Syndrome Medical Interest Group was formed. And that's where doctors who do kind of what I do started to get together and decide, maybe we should be a little bit more rigorous in our opinions and what we should be putting forward in terms of guidelines. And so it was in 1999 that medical interest group and the American Academy of Pediatrics got together and published official guidelines. And they were most recently revised in 2011. And it was a big revision. In fact, one that many doctors in the community may not even be aware of all of the changes that came about. And so we'll be talking about those changes today as well. And then there should be hopefully a new update within the next several years looking at what is the current evidence showing now moving forward and what we should be doing for people with Down syndrome. So what we'll start with is the first part of the guideline is in terms of genetics. So when there's a new baby born, it's important for the doctors to always send a karyotype or a chromosome analysis for the baby because in this era now, of course, you guys are probably aware in the literature, in the lay press even, that there are new ways of diagnosing Down syndrome even while the baby is inside mom. But it's really important for once the baby is born to send confirmatory chromosome results for many reasons, and we'll talk about that. But when we look at the chromosomes of this baby boy who has Down syndrome, you can see there with the circle and the arrow, this baby has 3 chromosome 21s. This is the most common type of Down syndrome that we'll see in about 95% of people with Down syndrome. This is not the type that's hereditary, future pregnancies for that particular couple or for the siblings of that child. It doesn't have an increased chance of any significance for that. But the one that we really want to look for is this type, which is the translocation type of Down syndrome. This is in about 3 to 4% of people with Down syndrome. And here you can see one of those chromosome 14s, the one with the arrow next to it, is a little bit longer than the other one. That's because there's a chromosome 21 attached to it. And so this boy has 3 chromosome 21s, it's just that one is attached to that 14. And the reason it's important to know this is because this does actually change how they would do genetic counseling for the parents, because in this situation, the parents would be offered chromosome testing for themselves because one of them might actually be carrying that elongated 14-21 combination. And for example, in this case, this is the father's chromosome. Now, the father does not have Down syndrome, but you can see he's got that 14-21 combination, and so he would have a higher chance of having future children with Down syndrome. And so it's important from a genetic counseling perspective, if the family was interested in knowing, do we have an increased chance, the only way to know for sure is by checking the parent's chromosome if the child has that translocation type. So one of the main reasons that we would want to check is, one, to check if the baby has translocation type, if one of the parents are carriers, and also important for parents to have in their folder on the child a copy of the chromosome report. And the reason for that is there are going to be certain times in that child's life where knowing that they have Down syndrome may offer them services. I know in Pennsylvania, for example, medical assistance or SSI, those types of things, you need to be able to have proof that the baby has Down syndrome, and that proof is the chromosome report. So important for the families to have a copy of that. At our clinic visits, especially the initial ones, we make sure that the families have a copy somewhere. So the next part of the guideline that we'll talk about will be cardiac related. Now, this is the most common thing that we think about. When we think about Down syndrome, we often think about heart issues, especially for the babies. And that's because about half of them will be born with some sort of heart issue. Now, not all of them are going to require any type of surgery, but in about half the cases there will be something. And the most common one is this thing called atrioventricular septal defect, which I'm going to show you in a picture format here in a second. But then you can also have a variety of other heart issues, and the only way really to know is by doing an echocardiogram on the baby, and we'll talk about that in terms of the guidelines here in a couple of slides. But this is what an atrioventricular septal defect looks like. And so I don't think this thing has a laser pointer with it, but you can see here that what they're showing you there in that number, they've numbered this. So number 1 is showing you that there's a hole between the upper chambers of the heart. Number 2 is showing you that there's a hole in those, number 4 is showing you that there's a hole in the bottom chambers of the heart. And then numbers 2 and 3 are showing you that the valves between the upper and lower chambers are also what we call atretic, or not fully formed. And so because of all of this, there's mixing throughout the whole heart of all of the blood. So we want to keep our blood that's oxygenated separate from the blood that's not oxygenated. And in this situation, with this type of condition, there's going to be mixing between all of the chambers of the heart. So, of course, this is going to require a surgical repair. This is the atrioventricular septal defect that we see in so many of the babies that are born. And so when we think about cardiac surgery and Down syndrome, for most of the people here, you would think, well, of course, cardiac surgery, if the baby needs it, they would get it. But it really wasn't until the early 1980s where cardiac repair was even routinely offered to people with Down syndrome. There was this misconception that with Down syndrome, the risks of heart surgery were too great. And so because of that, they weren't given heart repair, and so those babies with atrioventricular septal defect or many of these other heart lesions would go on to develop what's called pulmonary hypertension, or high blood pressures in the lungs. And by the time that happens, it's too late. You can't really overcome or surgically repair that high blood pressures in the lungs. And so it's really a sad commentary, to be honest with you, on medicine in general, that it took that long to really get to that point that we would routinely offer heart repair for people with Down syndrome like we would for any child. And what they do nowadays is surgery is done. They try to wait as long as they can, mainly for technical reasons, so that the baby's a little bit larger, can handle anesthesia a little bit better, and also so that technically the surgeons can go in there and do their thing. It's a lot easier to do that on a baby that's a little bit bigger than it is on a newborn. And so around 6 months of age is when we really try to get the babies to before doing the heart surgery, but sometimes they can't wait that long, and they need to have their surgery done sooner because of issues that pop up, and so the cardiac surgeons will do that a little bit earlier if needed. And then this is really great, is that people have studied that false conception we were talking about before about how people with Down syndrome don't handle cardiac surgeries well. And in fact, what they found is that people with Down syndrome, in many cases, handle surgeries better, cardiac surgeries better than people who don't have Down syndrome. And so it was really nice to see these articles that have started to come out showing that kids with Down syndrome do really well with heart surgeries, especially in the right places where they're being done. So the guidelines then from that recommend that every baby with Down syndrome have an echocardiogram done. And it's not enough to have the echo done when the baby's still inside mom. It has to be done after they're born to really have a very good image. And that's it's again, like many of the guidelines, that's right, it's a good thing, but it's hard technically. Let's say you live somewhere where there's not easy access, let's say to a pediatric cardiologist or an echo lab. It becomes a challenge, but many of these guidelines you can do locally. Some of them you really need to go to a place where they're trained in cardiac care, even if it's a little bit of a drive, and this is one of them. Getting that echocardiogram done somewhere where a pediatric cardiologist can read it is really going to be most beneficial. I know in Pittsburgh, and probably in other hospital systems as well, across the country, they've contracted with community hospitals around the region, and then they do the echo locally and send the images to the cardiologist at the city hospital. And that may be an option as well, but definitely important for all children with Down syndrome to get an echo in those first couple of months of life. And then after that echo, if the babies as they become children, don't have any cardiac symptoms at all, then they really don't need a new echo done. Unless the doctor hears a new murmur or the family is noticing some fatigue or chest pains or something like that, the first echo is really the only one that is required. Oh, and as we go through each of these systems, if you have questions that come up, just save them for the end, write them down, and then we'll definitely have time, I think, at the end to answer them. And like I said, we have those Ask the Doctor sessions that are you'll find in your schedule as well as options. So the next system we're going to be talking about is the gastrointestinal system. And the big thing with gastrointestinal system is when the babies are first born, they can be born with obstructions anywhere along the GI tract. So from mouth all the way to exit, there can be blockages along the way. And all of these are examples of blockages that you can find. And so when babies are born, the doctors really need to be paying attention to if there's vomiting or if there's delayed passage of bowel movements or something like that, that there might be some sort of obstruction along the way. But also GI issues can develop later on, meaning non-congenital means not born with it. And the big one that we see a lot of is reflux. A lot of kids with a lot of babies and also older kids with Down syndrome will have issues with reflux. And reflux, we really don't have great management for reflux, to be honest with you. Medications that we have available will reduce the acid content of the stomach, but they don't stop the reflux from happening. And so, thankfully, it does seem to get better as the kids get older, especially after they pass their first birthday, definitely by the second birthday, when they're getting to be more upright, that reflux doesn't happen quite as often. But it is a challenge in terms of management, medical management for reflux. And the other things we think about celiac disease, anytime you come to an NDSC convention, you'll always see those gluten-free options in the menu. And the reason for that is that gluten, which is found in wheat products and other types of grains, will also have gluten in them. Can cause not so much of an allergy, but just a reaction within the intestinal system that is known as celiac disease. And the kids can present with diarrhea, bloating, poor weight gain, and a myriad of other things, even behavioral issues, things like that, can come along with celiac disease. And it is pretty common. The difficult thing with celiac disease is that if somebody with Down syndrome has celiac disease, they do the testing, they have it, but they're asymptomatic, meaning they don't have any of that diarrhea, bloating, those types of things, then really the data shows that they don't have any long-term consequence. And so the reason that's important to know, so if you or I, if you don't have Down syndrome, if you or I have celiac disease and it's asymptomatic, we have a high risk of getting what's called lymphoma, small intestinal lymphoma. But people with Down syndrome don't seem to get that. And so the question came up, do we really need to be screening everybody for celiac if all we're going to do is put them on a really restrictive diet and not have any long-term changes in the outcome? And so that kind of led to the guideline change we're going to talk about in terms of we don't necessarily have to screen everybody with Down syndrome for celiac disease unless they have symptoms. The next one we're going to talk about is constipation, and I also put on there, also known as diarrhea, and you might think, what is he thinking? The reason for this is if you look at this x-ray I put on here, on an x-ray, black is air. And anything that's kind of solid or grainy looking in the abdomen is typically stool. And so this child came, and the main concern that the family had was lots of leakage of stool, lots of what they call diarrhea. And then the more history I got, and then of course this x-ray showed lots and lots of backed up stool. So more often than chronic diarrhea, in terms of what I see in my clinic population, is constipation with kind of an overflow of liquidy stool around that big hard ball. Hopefully you guys all had your breakfast already and you're not eating it now. So that's a big question. Whenever our family comes in with that concern of diarrhea, we really talk more about potential for constipation because that's far more common in the kids that we see. And then feeding issues is a real problem. It starts in many of the babies right in that newborn period. If anyone in here, breastfed your child with Down syndrome, you probably know it was maybe a little more challenging than it was maybe for a typical developing child that you had. We have some families at in Pittsburgh. We have a lot of families that have large number of kids, and I've had mothers come in with their 10th child saying, I breastfed 9 of them, why is this one so difficult? And a lot of the issues for the newborn breastfeeding is because of the lower tone that a lot of the babies have in the mouth. They can't get that good latch, they can't generate that strong suck. But the worst advice that I've heard people be given is, oh, just give up, it's not worth it. And that's just wrong. We really work in our center to help the mothers find the appropriate lactation advice to be able to really breastfeed, if that's the goal, because breast milk, of course, is the best thing for babies, especially babies with Down syndrome, because of some of the immune issues we'll be talking about. Breast milk has a lot of immune improving properties. And so we really support families. If they want to breastfeed, we'll give them as much support as possible to get those kids breastfeeding, because it is not impossible, and in fact, it is very possible to breastfeed babies with Down syndrome. And then moving later in life with the feeding problems, a lot of kids will have some oral texture aversions. They don't want that, crunchy food, or maybe they don't like mixed textures and things like that, or they have difficulties with swallowing, gagging with feeds, those kinds of things. We see a lot of those types of issues in our clinic, and we use our feeding specialists quite a bit to help us with managing those issues. So when we look at the guidelines in the 2011 guidelines, we talked about babies being born with obstructions. So they say definitely, watch for that. If there's any babies with vomiting issues or constipation issues, we need to be aware of those obstructions. And then screening for celiac disease only if there's symptoms. And I listed some of those symptoms there, but there's if you look up celiac disease, you'll find a whole list of potential symptoms, but we really don't routinely screen for celiac anymore unless there are one of those symptoms. Okay, moving on then to the next section, which is the respiratory issues that we'll see in Down syndrome. We talked about what's the pulmonary hypertension, which are those high pressures in the lungs. We definitely watch for that from a pulmonary respiratory issue that we might see. Chronic congestion is a real issue, and it oftentimes gets treated as if it's an infection and things like that, but many times it's just because anatomically the airways tend to be a little bit more narrowed in the patients that we follow, especially in the younger age kids. And so they get chronically congested and they have a hard time maybe even with snoring, and we're going to talk about that here in a couple of slides. Because of that congestion, they tend to hold on to the fluid in their nose. So when people with Down syndrome get colds, many times those colds last forever and ever. It seems like 2 or 3 weeks. And some of the families will say, in the wintertime, they're sick all winter long, and then summer comes and it seems to get better. We've even had some families move down to Florida to try to avoid all that chronic congestion stuff that we see up north. And croup is a real issue. Croup is that narrowing of the airway, usually from a viral infection. And if you've ever had a child with croup, you know how scary it can be because it's almost like they're choking. They can't get a breath in, kind of sound that they're making, and that barky cough and those types of things. So we see croup a lot more commonly in people with Down syndrome, mainly because of that narrowed airway like we were talking about. And so when we think about the guidelines when it comes to respiratory issues, for babies that are born in the newborn nursery, they recommend, especially if there's any heart issues in that baby, that they can tolerate being in a car seat. Because you would think, well, can all babies be in a car seat? Not necessarily. Because especially if there's any type of already compromised respiratory system, being in a car seat, sitting up, or sometimes, especially with the lower tone that so many of the babies are born with, kind of folded over, actually obstructs their airway even more. So you need to make sure that they can tolerate a car seat. And so most of the newborn nurseries will do a car seat safety test before the babies would go home. And then if they're having any of that noisy breathing, that's stridor, or wheezing, or heavier breathing, then ear, nose, and throat typically will get involved early to make sure that there's not anything else further narrowing their airway. And then a big thing that I talk to pediatricians and family practitioners about, but I make mention also here, is that just because somebody has Down syndrome and they get a cold doesn't mean that it's necessarily caused by bacteria. And one of the things that I see too frequently is that the well-intentioned families and doctors will really try to push to give antibiotics early. And let's say there's 2 days of a runny nose. We know that there's lots and lots of side effects to antibiotics, some right then and some later on down the road. And so really important to follow kind of our typical pathways. If there's not signs that it's a bacterial infection, high fevers, symptoms going on for 10 days, those types of things, then it really probably is worthwhile to wait a little while because the risks of antibiotics oftentimes will outweigh the benefit, especially early on in a cold. And then kind of similar to the respiratory, but a little bit different, is the ear, nose, and throat issues that we see. So a lot of ear infections, especially in the early part of their life. In the first 6 to 8 years, I would say, kids with Down syndrome get lots and lots of ear infections. And they're such a challenge because the drainage of that ear, the tube that drains it, is narrowed in many people and often takes a different course in Down syndrome, which makes it harder for that middle ear fluid to drain off. So they get a lot of infections, and it takes a lot longer for them to clear their ear infections. And so many times they'll have what we call persistent middle ear effusions, meaning it may not be infected, but there's fluid sitting behind there. And if there's fluid in your middle ear, it can affect your hearing. And we already know that speech oftentimes is delayed. And so if you delay it further by muffling the hearing, it can be a real issue. So we do a lot of ENT, ear, nose, and throat referrals, mainly to kind of keep track of those ears. It can be also very hard as for a doctor to look at the ears. I'm sure many of you have maybe even heard about your kids, it's really hard to see their eardrum because the canals are so narrow. And that's the thing we see, so it makes it hard to even see the ear fluid, and so that's a challenge as well. Hearing loss over the lifetime of somebody with Down syndrome is quoted at about 50%. Now, that's not permanent hearing loss. That also includes the kids that are 5, 6 months old and have that fluid in their ear, and they don't pass their hearing screen because of that. But once the fluid comes out, their hearing is improved. But it is something we definitely watch for in people with Down syndrome, even throughout the whole lifetime, to make sure that their hearing is optimal. And then sinusitis, we talked about how it's usually viral, but when to consider bacterial is when it's prolonged or there's high fevers involved, things like that. And then the big one I put in red is obstructive sleep apnea, because this is the one that caused probably the most discussion when it came to the new guidelines when they came out in 2011. Obstructive sleep apnea is really, really common in Down syndrome. And there's significant potential risk if it goes untreated or undiagnosed. One of those is that pulmonary hypertension, again, that high pressure in the lungs that we try to avoid at all costs in people with Down syndrome. They tend to be a little bit shorter than their peers, which, as we know, height tends to be something that many of our friends with Down syndrome struggle with getting to that ultimate adult height that they wanted. And then sleep apnea on top of that does make the final adult height less if it's not treated. It increases the chance of obesity, having sleep apnea. And then also being obese increases your chance of sleep apnea. So it's like this never-ending cycle. Sleep apnea makes you more obesity makes you more likely to have sleep apnea. So that's an issue. More reflux in people with untreated sleep apnea. And then, because of the lack of sleep, now, for those of us who were out last night, not me, but many of you maybe were out having a good time at downtown Disney or whatever there is, and then you didn't get much sleep, and then today you're going to take a nap, not in my lecture, but at the one next, right? And so, but young children get hyperactive. You guys have seen that. At the 9, 10 o'clock, the kids you kept up too late at the pool last night, they get real revved up many times, and they don't get sleepy. Same thing happens in people with Down syndrome with sleep apnea that goes undiagnosed. Because the brain isn't getting the rest that it needs, that restorative sleep doesn't happen, and they end up being high energy, and many times I've seen them misdiagnosed as oppositional defiant or ADHD or something like that, when really what it is sleep apnea playing a big role in that. And then, of course, it's going to affect school performance. Kids with untreated sleep apnea are not going to be able to learn. Try learning, you go to bed at 4 a.m., wake up at 6 a.m., and try to learn. It's impossible. And that's what the brain of somebody with sleep apnea is like. They're just not getting the restorative sleep to be able to learn new tasks. And then there's this interesting potential possibility of earlier onset of dementia. We're going to talk about Alzheimer a little bit later. It's not something that is quite as common as was once thought. Certainly more common in Down syndrome, but not where it was in terms of what they used to tell me when I was in medical school. But with sleep apnea, there's this concern that it might even make dementia happen more often and earlier. And so again, this is really serious stuff. So we don't want somebody to have sleep apnea and not know about it or not treat it effectively. Why does sleep apnea happen so frequently in Down syndrome? This picture, it shows you a lot of the issues that people with Down syndrome have that increases their chances of having sleep apnea. They tend to have a smaller mouth cavity, so relatively then, the tongue tends to be a little bit larger in comparison to the size of the mouth. And then that tongue will go backwards when they sleep and obstruct their airway. Or they might have adenoids or tonsils that are larger than and will block off that space when they sleep and cause those obstructions. They can have things all along their airway. I'm not going to go through each and every one of these things, but these are everything on this picture, which you'll have in your slides, is an area of potential narrowing. So one, it shows you why it happens more frequently, and two, it shows you why it's so hard to manage, because there can be many, many areas of obstruction along that airway. And then you see here in this picture, when this person is sleeping, the guy on the top, when he sleeps, he's got very nice airflow right into his airway. But then you can see each kind of stage, especially that bottom picture, you can see how in this person everything gets obstructed when they sleep. Because when you sleep, your tone drops. And you know that people with Down syndrome already have a little bit of a lower tone. And that tone drops even further when you sleep. And so therefore, all of those airway structures move backwards. And so people will say, oh, my child with Down syndrome has the strangest sleep pattern. He sleeps folded in half at the waist. Have you ever heard that before? And I say, oh, yeah, all the time. It's something that we see a lot because it helps to pull all those airway structures forward. So people with Down syndrome will naturally come up with ways that will keep that backward positioning of their airway structures so they can actually get air while they're sleeping. So families will say, oh, so I shouldn't be recorrecting where they sleep. And I don't. I tell them, no, don't. But we should probably figure out where the obstruction is and move forward with evaluation for sleep apnea if they mention strange sleep positions and things like that. So when it comes to the guidelines from the ear, nose, and throat perspective, all babies across the country get a hearing screen. And if they fail the newborn hearing screen, all babies get a repeat hearing screen within the first 3 months of life. But where it becomes more specific to Down syndrome is that we continue to recommend hearing screens moving forward, especially in those first 3 or 4 years of life, because that's when speech is actively being acquired. And so if they don't have great hearing, they're not going to be able to pick up their speech as well. And so we check their hearing every 6 months in those first few years of life. And then after that, they get annual hearing screens as part of the recommendation to make sure that they don't have any hearing loss developing over time. Because a big part of these guidelines is prevention. And if we can identify something like hearing loss and manage it before they ever have any issues related to it, then that's the best thing we could possibly do. And then if there are concerns for recurrent ear infections or hearing loss, then we refer them to the ear, nose, and throat doctor. And then the sleep study recommendation, which is, again, a huge challenge. You know, for me in Pittsburgh, it's pretty simple because we have a big children's hospital. We're able to get kids in for a sleep study fairly easily. But then the families that I see that come from 4 hours away, it's a real challenge to find a place that can do a pediatric sleep study. And not only that, even if they say, oh yeah, we can do a sleep study, one, are they equipped? Do they know how to manage a lot of the facial sensitivities that the kids will have, and putting all those leads and wires and all this other stuff on them can be a real challenge for them to stay on. And then two, do they have a pediatric sleep doctor who's able to interpret the study? Because the interpretation of a sleep study requires knowledge of pediatric sleep. And because adult sleep and kid sleep is different. And so how you measure that really requires somebody who's familiar with pediatric sleep studies. So again, similar to the echocardiogram, the sleep study is one of those tests that is worth the drive to the local or closest children's facility that is able to do sleep studies and interpret them correctly in kids. And we'll have special expertise, hopefully with the techs, knowing how to work with people with Down syndrome because of the facial sensitivities that so many of our friends have. Okay, so moving on to eye issues. Eye issues are very, very common. So this is a list of a lot of the eye issues that we can see in people with Down syndrome. The girl on the top has esotropia. The right eye is looking inwards while the left eye looks straight. And over time, if that goes unmanaged, it can lead to actual blindness in that right eye because the brain will start to ignore that signal. So it's important to evaluate and manage that. The picture in the middle is the corneal clouding that we will see with cataracts, and so and then the person at the bottom has what's called keratoconus, which happens later in life in some people with Down syndrome. And essentially, you can see they call it conus because it looks like a cone off of that eye. And that picture is why I didn't go into ophthalmology, because it's freakish how they have to, retract the eyelids like that, and during surgery they're looking at you. Oh, I don't know, that wasn't for me. But we do see a lot of different eye issues, especially in our kids. And so that really leads to where the healthcare guidelines went with eye issues, is that we check everybody for what's called a red reflex. You see that picture where there was that clouding? Typically when a doctor looks at the eyes, you should see a red response back out from the eye. That's because of all the blood vessels that you are seeing, the reflection of those blood vessels. If there's something blocking that, then that's a concern because it's blocking the vision as well. So the doctor should check for that at every visit. Strabismus is that eye wandering thing that we saw in the girl in the top picture. And then nystagmus is an issue where there's these rapid eye movements that go side to side in kids. And often they get better as they get older, but sometimes the ophthalmologist will recommend further testing if they see that lasting longer. And then for any time a baby has concerns for eye issues, they should get referred right away to an ophthalmologist. But if there are no concerns, they still should see an ophthalmologist. And the referral pattern I put down here at the bottom from the guidelines is, within those first 6 months of life, but then really pretty frequently for the rest of their life. And an ophthalmologist is different than an optometrist, and so it's important to look for somebody who is a medical doctor who works with the eyes, an ophthalmologist, to see the kids at least based on these guidelines, this time frame type of thing. So endocrine issues, so endocrine system is your hormonal system, and the most common thing that we see in Down syndrome when it comes to endocrine issues is hypothyroidism, which is underactive thyroid. We see that in a lifetime of about 15 to 20% of people with Down syndrome will develop hypothyroidism. Sometimes the babies are born with it. Actually, almost 30 to 40 times the rate of the general population, a baby with Down syndrome will be born with hypothyroidism. And so it's important to recognize that it can happen really anytime from birth all the way through their whole life. The ones that happen later in life after the newborn period is typically an autoimmune issue, meaning their immune system kind of gets overactive. And we see that a lot in a lot of different conditions with Down syndrome. I'll talk about that in a few slides. But thyroid issues, oftentimes there can be antibodies that the child themselves or the adult themselves will make that will attack their thyroid gland and make it not function anymore. So that's why it's important to keep repetitively looking out for thyroid issues in people with Down syndrome, because many of the times the symptoms of hypothyroidism can look just like what we see very commonly in Down syndrome. So things like constipation or dry skin or learning difficulties or excess fatigue and those types of things that we see in hypothyroidism, we see in Down syndrome too. And so that's why it's important to always stay on track with the thyroid screening, and I'll show you when they should be screened here in a second. Hyperthyroidism, or overactive thyroid, also happens at a higher frequency. That's what's called Graves' disease. It's kind of a scary sounding term, but it's not like grave, like there's no treatment for it. We do also think about that. Much less common than hypothyroidism, but it certainly does happen in Down syndrome. And then type 1 diabetes, that's the autoimmune kind of diabetes, the childhood onset type of diabetes, also happens more frequently in people with Down syndrome. So we do definitely think about that as well in the kids. And so just kind of a slide just to show you how the thyroid system works, because there's a lot of information and misinformation out on the internet about thyroid issues, and I think it's important to understand how the whole system works, and it also helps you to understand why the doctor is sending what tests. And so this is a little bit, it looks busy, but essentially what it is, the picture on the left is showing the same thing as the diagram on the right, and just in a little bit of a different way. So your brain in the hypothalamus releases what's called thyroid-releasing hormone. And that tells your thyroid gland that it needs to, tells your pituitary gland that it needs to release what's called TSH. And you guys have probably seen that. That's the one that we measure. TSH is what tells us how our thyroid is functioning. And then TSH goes to the thyroid gland and makes it make thyroid hormone, which is T4. Okay, so TSH, T4, those are numbers that you probably have heard of, seen before. And then the really neat way that most of our endocrine system works is then that thyroid hormone is made and then goes back to those earlier steps and suppresses further production when it gets to the right level. It's kind of got its own set point type of thing that it does. And so if your thyroid gland starts to be underactive, then it's not going to be making that T4, which is going to make your pituitary say, hey, I've got to work a little bit harder, so your TSH rises. So that's why with hypothyroidism, it's kind of weird to think that the number goes up, but the TSH goes up because it's trying to make your thyroid gland wake up and do more work. But unfortunately, over time, in somebody with hypothyroidism, it just can't keep up. And that's why that thyroxine or thyroid hormone level goes down. So you'll see different folks out there with different opinions on what the thyroid normal levels should be and all that type of stuff. Thyroid issues are not new. They've been around for a long time. So management of hypothyroidism is something that is not a new thing. And so we definitely don't support the idea of thyroid replacement in the absence of hypothyroidism. It's something that I've seen on the internet a lot. I get a lot of questions from families about it too. So it can be potentially harmful to replace thyroid hormone when it's not needed. So that's why I bring that up. When we're looking at the symptoms of hypothyroidism, you'll see all of those things that we were talking about earlier there on the list. And hyper hyperthyroidism essentially is almost the exact opposite. When you get overactive, you'll see almost the opposite symptoms of hypothyroidism in every one of those things, except for poor growth, which happens in both hypo and hyperthyroidism. So if we have kids that are having a hard time gaining weight or maybe with their development or anything like that, we'll often check thyroid a little more frequently just to make sure that they're not developing hypothyroidism. So when we think about the guidelines, when it comes to thyroid, all of the state screenings screen for hypothyroidism. The problem is not all of the states screen in the same way. And so it's really important that a baby with Down syndrome get that TSH level sent. Because if they just check the thyroid hormone, that thyroxine, they'll miss the kids that are on their way towards hypothyroidism, and that TSH might be higher, and you won't catch it if you don't check it. And so we always make sure, in Pennsylvania, they don't automatically screen for TSH. So we always make sure that the babies get a TSH level sent before they leave the newborn nursery, because if that is showing signs of going towards hypothyroidism, the worst thing you can do is have a baby with hypothyroidism that you don't treat. Because thyroid is so important to all of the growth and development of that rapidly growing child. And so it's really, really important to identify it early. So all babies with Down syndrome should have a TSH level done either on the newborn screen or within the first week or two of life. And then after that, they should get repeated at this interval. So at 6 months of age, at a year of age, and then every year for the rest of their life, they should get a TSH level sent. Some doctors will send a TSH and a free T4. That's fine. It's probably just a little bit of an overkill. But especially that TSH level needs to be sent. And if the TSH level comes back abnormal, then they definitely want to check to see how much thyroid hormone is being made, so they'll check that T4, free T4 level as well. If the free T4 is low, then they should be started on what's called Synthroid or levothyroxine, which is essentially replacing what the body isn't making. And so it's really well tolerated once a day. The hardest thing about managing hypothyroidism is just making sure it's diagnosed. Managing it after that is pretty simple in terms of you just give them the levothyroxine and they get replaced what their body isn't making on their own. And then there's this strange phenomenon where the TSH can be high, but that free T4 can be normal. And in some kids, that ends up becoming hypothyroidism later on. And in some kids, it just resolves on its own. So we know that it needs to be followed more frequently. If that TSH level is starting to trend upwards, it might be a sign that that pituitary is telling the thyroid hormone to work harder, and we'll want to definitely follow those kids off of this schedule, maybe every 3 months to 6 months with their thyroid hormone to make sure they're not developing hypothyroidism. And I talked about this last part already. And then in terms of diabetes, like I said, type 1 diabetes is more common. And so if the kids are having excess urination, excess thirst, hungrier than usual, being more fatigued than usual, we'll also check their blood sugar to make sure that they're not developing type 1 diabetes, because again, that is more common in people with Down syndrome.